We can measure things. We can use pharyngometry, which I think is a wonderful tool. We saw this used in some of the presentations earlier this weekend. We can look at different landmarks of the jaw. We can measure, we can do a Muller's maneuver, which is well validated in the medical literature, to just measure the collapsibility of the airway. Don't overthink pharyngometry. What we're looking at is the collapsibility of the airway. All right, and can we improve that with our appliance therapy? Here's an example of the red up in the upper left is that's the Muller's maneuver, collapsibility of the airway. In the lower right, same maneuver with just an arbitrary bite block in the mouth. All right, and I don't want to really dive into the numbers. I just want to tell you that yeah, there's an overall mean net increase in the diameter of that caliber of that airway. But I need you to realize that we don't, those of us who have pharyngometers, it's not about where the airway is that moment in time. Because we haven't titrated the appliance and we haven't given the airway a chance to heal, have we? Here's your pharyngometer before we do any type of test bite. She collapses quite a bit. When we do a test bite on her, there we go. We see a dramatic improvement. And remember, what I have my girls do is just have the patient open, rest on 2 cotton rolls and bring their jaw forward, shoot a little bit of bite registration material between the back teeth, and run another pharyngometer test on them. Was there any change there? Well, there was some change there. So by bringing that jaw forward, all we did was we reduced the collapsibility of the airway. That's very interesting. That increases my prognosis. Okay? Because this guy is he's a senior triathlete. Chief complaint, headaches, jaw pain, TMJ pain. He gets 1 to 2 cluster headaches per day. He wakes up in the middle of the night with a cluster headache. Variety of trauma. He's an athlete. Stiff neck. Sleeps 6 hours. He says unremarkably, but he wakes up with a headache every day. So, I'm starting to think, what? Oh, you haven't seen Jack. Here we go. And this is what he looks like. So could Jack, what do you think he is? What's the problem here? TMD, don't tell the punchline yet. Well, he's looking sort of like TMD. Look at the guy. He's thin. Probably has a BMI of 20, 21, 22. Range of motion isn't real great. So I charge in there articular cartilage disorder, capsulitis, mandibular discrepancy to cranial base. Other things I didn't show you, he had an Epworth of 2. So he couldn't be a sleep apneic, okay? We look at his bed partner survey. And I don't know if you can see that very well, but really, no. The only yes is, does the patient appear refreshed upon waking? Yes. So do you still think it's airway? Probably not, right? If this weren't a sleep apnea lecture and this were a TMJ lecture, I could have easily taken you down that path, couldn't I? Couldn't I? Okay, sure. So I don't really have any reason. So I put an orthotic in him. That's great. Okay, so you guys, everybody in this room taught me this. So I'm just showing you how I'm doing. Put the nighttime appliance in him. He doesn't collapse much. He's looking pretty good there. So here we are on 6-4. Headaches improved 80%. TMJ noise eliminated. Jaw pains resolved. Right? Good. But he continues to wake with debilitating cluster headaches. And I didn't tell you this in the beginning, but I was sort of it for him. This has been going on 30 years. He has seen every doctor, had every test, had every scan, poked, prodded, been on every pill, antidepressants, muscle relaxants, everything. Nothing took care of these headaches that he had. And I was it. Basically, he told me, hey, no pressure, like Terry today, no pressure, but you're on, okay? You're it. Because he kind of alluded to the fact that if this didn't work, he was done. He's tired of 30 years of this stuff. And I don't blame him. So we go back. Instead of treating him more, I go back to the data and I kind of look at this pharyngometer and I go, well, that's the initial exam. And what did I sort of miss on that? The fact that, let me go back. Sorry. What did I miss? The fact that he did collapse. If you look between 12 and 17, there was a dip, there was a collapsibility issue. But I was so sure that I really didn't need to look. I was so sure he was a TMD patient. It sounded just like a TMD patient. I didn't look at this. So I went back and looked at the data again. I said, oops, I think I kind of missed something here. And so, again, I didn't have a lot of other things to go on. So I looked at his bite test, that arbitrary bite test that I just told you about. Really did change the caliber and collapsibility of his airway. So I said, hey, Jack, I don't know why I'm doing this, but let's run a watch pad on you. So we did a watch pad on him, and he had a PR, and I said, this is the other thing I do. If you want, he wouldn't go for a PSG. Like, he was done with tests. And I said, okay, Jack, I'm going to run this on you, and if you fail it, you agree to go for a PSG. How's that? Will you do that? Well, okay, if I fail it, then I'll go. So he comes up with a PRDI of 17.4, and so he failed it, didn't he? All right, that's not normal. So I was hoping it would be like 85, off the chart. See, you're dying. But so I had this very small hook to hang my hat on, didn't I? So I said, well, okay, so now you're going to go. So he goes. He has his PSG. And let me read this to you. I want to drop you a quick note. Is this case really now, this guy is Dr. Michael Lucia, board-certified sleep specialist, board-certified family practice and internist. He's kind of a stud, okay? Dear Brian, I want to drop you a quick note as this case really impressed upon me the importance of assessing the craniofacial anatomy. Ooh, they love those. These love that word. Okay, Mr. Withers is a patient you know sent to you for evaluation of possible TMJ as a cause of his headaches. He has normal weight with a BMI of 24, Mallampati of 4. He is, well, that should have been a little tip-off. He is asymptomatic from a somnolent standpoint. Now, this is the sleep specialist, okay? His sleep study, as you will see from his report, shows extreme apnea with an apnea index of 85 and prolonged events lasting as long as 328 seconds. So what, right? Sack up, Jack. Come on. 328 seconds for obstructive hypopnea. His hypoxia was fairly profound as well, as he has severe hypersomnia with a latency of less than 3 minutes to sleep. Latency of less than 3 minutes to sleep, despite his mention of no daytime symptoms. In addition, he has severe tachybrady syndrome with heart rates going from 50s to greater than 100, and significant sinus pauses noted upon his EKG. I will keep you informed of his progress, but clearly he will require CPAP intervention, as his hypoxia and sleep disruption is likely contributing to his cluster headache significantly. Okay, so thank you again, as always, for your referrals and great collegial support. So what do you think? Okay, I showed you his history. I showed you some of his range, his stuff. What was missed? And how often do you think Jack would get missed? How many people in this room, beyond, because it fooled me. I mean, I was like, what else can I do? Well, I'll send him for a sleep test. Okay, I didn't have a lot to hang my hat on. The watch pad said he was a 17. What was he really? 85. So you got to keep in mind that the ambulatory sleep study equipment will always give you a diluted value. Sometimes diluted, but diluted. Okay, so he had been gone on. I mean, this had been going on forever. What do you think would have happened if he wouldn't go see my pain psychologist? What do you think he would have done inside of 6 months? Suicide, maybe? Anybody ever have that happen to you? Not personally, but I mean, where you had a patient? Okay? I have. So, I mean, it's not fun. So, poor Jack, I mean, he was a culmination of decades of misdiagnosis, unnecessary treatment. Now, who picked it up? I picked it up. I would have liked to have presented this case like I got it. I nailed it right in the beginning. I grabbed him right by the shorties in the beginning, and I got it. But I didn't. I mean, he gave me no indication that he was sick. And how sick was he?
The Embletta uses the same software as a sleep lab. All right? I can take my Embletta data. It's all Embletta. The Embletta software. If they want the raw data, which they like to see my raw data, you can just send it to them, and they can evaluate it using their software. You can't do that with a watch pad. I bought 3. How many did you buy? Why else would we use pharyngometry? All right, evaluate the positional efficacy. Showed you these little jigs, and these are really brilliant. Okay, You can use different jigs, different sizes, and do different pharyngometric tests to see which vertical dimension might help the patient. So when we go back to on 4-2 was his initial exam, this was his original pharyngometer. Daytime is huge. He's an athlete. I mean, he's tough. Look at his collapse. Okay, minimum 1.23, average of 1.56. I'm willing to admit this, I did not look at this. I went straight to my ICAD scans, I went straight to looking at inclusion, I went straight to the TMJ, and I just really didn't look at this, okay? So it was kind of an oops on my part. But when I wasn't getting the job done, does that mean we need more treatment or more diagnosis? More diagnosis. So I went back over my results and data and everything we collected, and I looked at this and I said to myself, what in the hell did I miss? When you see a collapse like this, it's quite likely he's doing what in his sleep. Remember, this is best case scenario. And he's down here, okay, here's 2, 1.5, 1. Okay, his airway is very collapsible, isn't it? And I had overlooked it. But luckily, I went back and kind of took a look at it. I looked at the nighttime deprogrammer I put in his mouth, and it actually helped him. Okay, it actually helped him. Let's talk about rhinometry. Well, why would we use a rhinometer? Just make appliances, okay? Well, we talked about the landmarks. We've got the nostril, and we're looking at the posterior and anterior inferior turbinate. That's the big player. In your nose, let me go back. In your nose in terms of nasal resistance, most of it has to do with this inferior turbinate, a little bit with the middle, and none with the superior. So what we're really looking at is the nasal patency where it counts the most. So why would we use rhinometry? I mean, why? Why do you need to use rhinometry? Nasal patency, number one, you got to establish nasal patency. Number two, it's very non-invasive. That's why I've got one of my main pulmonologists, he's probably going to go to rhinometry. Okay? Number two, ENT communication, it's a recognition. If someone said to you, hey baby, 28 years. I mean, would you pay attention if I was speaking your language? Or 28 implants? What? Bam! He's like, what? 28 what? You want me to do what? You know? So it's really, it's recognized by our medical colleagues. Allergist referral, okay? You know, if you come in and your nose has a bunch of different measurements over time, and you know, that's an allergy. That's not a giant polyp, okay? And then oral appliance therapy prognosis. Again, directly affected by what? Nasal patency. Huh, very important. I mean, would you evaluate someone periodontally without x-rays and a periodontal probe? No, this is our x-ray and our periodontal probe. So let's talk about, let me show you a case where, without rhinometry, we might have screwed this up. So here's a lateral septum. Here's the airway, wide open. Anybody used to look in lateral septum? That's a wide open airway. That's beautiful, okay? But what I want to do now is let's cut through Barry, and let's take Barry C, not Barry G. I'd love to cut through. So I'm teasing, sort of. Anyway, let's take a look at the paranasal sinuses. So here we are in the front of it, just right through the tip of the nose, okay? Here we are moving back. Now, a normal sinus should look like this, shouldn't it? Big black hole, right? Normal paranasal sinus, here's your superior, middle, and inferior turbinate. And, oh, wait a minute. This is normal. What is that? That's us. Okay. That is where's the medial wall of the maxillary sinus? Gone. Okay. This is one fungating animal in there. Okay, here's a picture of the paranasal sinus. This is what the rhinometer is measuring. Here is the left side, normal, kind of like yours. Here's the left side. Here's the right side. There's something going on. See that? So do you think this alerted me to take a closer look at this guy's nose? Absolutely. Do you think I would have, if I didn't have instrumentation, would I have made him an appliance anyway? Would I have maximized the benefit of the appliance without opening up the nose? Vertical. So how would you know how much vertical to add? I mean, what would be a guide? Rolling the dice? Throwing a dart? Or maybe measuring? Appliance, And not everybody's going to get the same frame. All right, you'll be a home run. Okay, but we'd love to do a pharyngometer on you. It's probably a genetically small airway is his problem. And he might not collapse at all because he looks kind of fit. So his prognosis would be, we'll do the best we can and make sure he doesn't have any nasal patency issues. However, your prognosis for appliance therapy might be better than his. Wouldn't you want to know that? Or would you rather just kind of give everybody the same appliance and give everybody a Somnodent and just sort of do it the same way? Or might you want to tailor your treatment to that specific patient? That is my point. But let's say we find that by adding, say, 2 millimeters of acrylic in front, we might improve the collapsibility of their airway. Well, how easy is it to grind on this and add a couple millimeters of triad? We do that every day, probably 1 to 5 times a day in my office. We're playing with that vertical dimension. Is that substantive in terms of maximizing airway? Yeah, you've got AP, but you're also going to have vertical. So how would you know how much vertical to add? I mean, what would be a guide? Rolling the dice? Throwing a dart? Or maybe measuring? Well, how much? You're telling these people to open the vertical, but you're giving them no guide. 1 millimeter, 2 millimeters, 3 on odd days, 4 on even days. See, it becomes arbitrary. And if you've never used the equipment, it's easy to speak negatively about it.
Later, I'll tell you. Yeah. Actually, yeah. You know what? Put an ad in one of the magazines. So I'm not sure if it was this one or the first issue.
If you reposition them, what happens?
Now it's in blue, which is even harder to see.
Get the test so you guys could go over
I don't
it.
even know how to do that.
I'll do
I pushed every button on there earlier.
The one that says all off.
Now, before we even look at the data, what's he doing? Man, he turned around right away. Well, he wants to see what? He doesn't know what he's looking at. He wants to see it though. Patients are affected dramatically by this instrumentation. Okay? I don't care what your opinion of the instrumentation is. Patients want to know what their numbers are. So when we start doing this, and no one else in your community, let's say someone else in your community says they do oral appliances, all right? But they don't have instrumentation. I mean, and you do, who's going to have the greater effect, just impact perception on the patient? You are. I mean, you whipped right around. It's so funny. Patients just, yeah, okay, they want to see. And when you position your equipment, you have to be careful that they can't see the screen. Because you'll be right here, and they're kind of like, wanting to go over here and see the screen. It's kind of hilarious. But again, the assistants do all this. All these tests have been done by my assistants. I get the printed copy brought to me when I'm in with the consult.
Yeah.
Awesome.
So did his airway respond? Yeah. Substantially. You know, changing the oral cavity now because, one, because there's no tongue depressor in there, and two, we got this big plastic piece sticking in, so you expect a little change here, and it doesn't matter the least bit. But when we get through to the airway, the part of the airway that does matter, I mean, we saw a tremendous increase. We went from 0.85 size, you know, on average, an average size of 0.85 up to 2.5. That's almost normal. And a 299% change. At a minimum, the narrowest point from 0.6 to 1.29. It's not 2, but it's a hell of a lot better than 0.6.
So does this imply that you would benefit from the use of a mandibular advancing device?
More than implied. It strongly affects your prognosis. I would look at he's a 4 bicuspid extraction case if you didn't know by a smile.
So who's
Damn smile I did.
So
That smile.
who's going to write the prescription? I'll take it back with me.